Pandemic Influenza by Tatum Bowling. Some history about influenza pandemics. In 1918, H1N1 influenza pandemic had mortality rates of at least 50 million deaths worldwide and 675,000 deaths in the U.S. In the 1957 H2N2 and 1968 H3N2 pandemics, they had fewer deaths at about 1 million people. The 2009 H1N1 pandemic had fewer than 300,000 deaths for the first year. We have made significant progress since 1918, especially in diagnostics. In 1931, scientists began recognizing and diagnosing influenza by culturing eggs and cells and the use of influenza-specific direct fluorescent antibodies. In the 1990s, they developed point-of-care influenza tests such as the rapid immunoassays and the rapid molecular assays, which yield results in about 15 to 30 minutes. Laboratories now use higher complexity tests, which allow them to detect seasonal, novel, and emerging pandemic strains of the influenza virus much sooner. The CDC uses this data to monitor the virus and to develop vaccines. Another significant progress that we've made is the development of vaccines. The first clinical trial of flu vaccines was in the 1930s, and in 1942 they began large studies of the influenza vaccine. In 2010, the U.S. Advisory Committee of Immunization Practices have recommended annual vaccination for nearly all individuals 6 months of age or older. And during the 17-18 flu season, there were several flu vaccines formulations available, such as standard dose, high dose, adjuvanted, and more recently developed vaccines without eggs. Another progress we have made is the development of antiviral medication. The first antiviral medication, amantadine, was approved in 1966 and was widely used during the 1968 influenza pandemic. In 2005, rimantadine was approved. Both amantadine and rimantadine are no longer recommended for treatment because they have a high rate of resistance. In 1999, neuroaminidase inhibitors such as oseltamivir and zanamivir were approved, which lessen the duration of influenza and can prevent complications. And antimicrobial drugs have also been developed and are used to treat secondary co-infections. Another improvement we have made is we have better infrastructure and PPE. Since the 1918 pandemic, medical services have advanced significantly, such as the development of intensive care units, exceptional monitoring, and specialty care, and we also have mechanical ventilators now. Personal protective equipment has also been implemented for those that provide care to people infected with the influenza virus. The BSN essential that links to this the most is clinical prevention and population health. Nurses can encourage health promotion and disease prevention amongst people in order to improve the general health among populations. And they can do this by administering vaccinations, administering antiviral medications, and encouraging good hygiene efforts. The cues and competency based that goes with this the most is evidence-based practice. Nurses can help treat and prevent influenza pandemics by integrating current evidence into the clinical care that they provide. And again, they can do this by using PPE, administering vaccines and antiviral medications, and practicing good hygiene. And the question that I have is, what are some other improvements that could be made in the healthcare field that would contribute to lower mortality rates amongst people infected with the influenza virus?